want to ask a question, you can go up there, and when you turn on the switch, it takes about 3 seconds for it to sync up. So just be patient. It will come online, and you can ask your question. We will be putting you live on the stream, on the live feed when you ask your question, so be wary of that. Otherwise, we're going to hand it over here, and they can get started. Thanks.
Good afternoon, everyone. I'm Sean Byrne from Innovo. We administer the Public Employees Insurance Program, more easily called PEEP. There's 3 handouts that hopefully everybody here live grabbed, and I know they've been sent out to all the staff. Before we go through those, I want to start out with just a little bit of background, some history under the program. The program was created by the state legislature back about 30 years ago. It is a true public plan. It's administered by the state of Minnesota, and that's very important under this program because we get to piggyback or leverage off of the state of Minnesota employees. That really helps us in that we're able to piggyback on the contracts that the state signs, so we have some of the best administrative rates out there and great options as far as multiple networks rather than just one network under the program. But at that point, we separate from the state employees, and all rating and risk decisions are made by PEEP. So the program's been around for 30 years, but things really changed back in 2009. That's when we created what we then called the school pool. Initially, we wanted to talk to as many schools as possible that wanted to come together and be rated jointly, rather than having their own experience dictate what happens at renewals. We wanted to pool as many school districts together as possible, so we were spreading that risk over a large base. The law of large numbers said when you spread risk over a larger base, you will have less volatility. And that was the whole point behind what we were trying to do with the pool back in 2009. Before I talk about the pool, I do want to just talk about the statute that created PEEP. PEEP is unique in that there are 2 ways for groups to join PEEP. The first way is a district sends out an RFP, request for proposal. It's answered and they decide this is the program we want, and everybody goes that direction. That's the normal way that school districts and employers in general have changed insurance over the years. But the PEEP statute also had a second avenue. Under the PEEP statute, a bargaining unit, as long as they jump through a couple hoops and give some notification, a bargaining unit can make their own unilateral decision as to whether or not they want to participate in the program. I wanted to point that out because that's where the Evelyn Gilbert teachers came in under the program using that statute. They've been in the plan for, I think it's 8 or 9 years now. So there were 2 ways to come into the program. From PEEP's perspective, we'd rather have the whole group together. That's the easiest way to handle things. But just so you do know, there are different choices under the program. The first handout that I'm going to talk about is why the PEEP pool is an ideal partner for your group. As I mentioned, back in 2009, we started putting this pool together. At first, we thought it'd be great if everybody could come in at one rate. It would simplify things. We talked to about 40 schools. We gathered all the information, and when we looked at it, their risk or their rates were very widely dispersed. So the thought of just coming up with one rate in the middle, if we did that, all of the group with high claims would jump into your pool. The groups that were doing better with low claims would probably stay out. You'd be in a high-risk pool that would blow up in a year or 2. So we decided we couldn't do things in that fashion. So what we decided to do was set premium tiers initially for groups. So when a group looks at joining PEEP, what we do is we look at their most recent 12 to 24 months of claims. From that, we basically set a risk factor. We use A through F. With groups in the A tier, they're very healthy, very low claims. Groups in the F tier, they've had some difficulties and they've had higher claims lately. We want to make sure that we could draw both healthy groups and unhealthy groups into the program. So initially, rates are differentiated among those tiers. But the important piece is, once you come into the pool, all of the future renewals are based on everybody's claims experience. So once you're in the pool, all the future renewals are based on the total claims of all the members of the pool. Initially, when we started the pool, there were, I think, 12 schools that were willing to be guinea pigs since there was no track history, a lot of them up in the range area. But we started out with 12 schools. The sheet that says why PEEP is an ideal partner, since we are a public plan, we are totally transparent. Here is every renewal that we've had since we created the PEEP pool back in 2009. So as you can see, in 2010, we had very little claims experience. The groups were just still coming in, so we had to use a basic trend increase of about 8%. But after that, we were able to use the actual claims experience of all the groups, and you'll see in the next 2 years, we actually dropped the rates by 10% over that time frame. So the program was working very, very well. And I don't want to go through every one of the renewals. The bottom line is the whole idea of spreading risk over a larger base has worked very, very well under the program. Our 12-year average is under 3.5% as far as average increases. And there's no program over that time frame that can really match that record. Off to the side, there's a few points that I just want to talk about. PEEP itself is a self-funded trust, which means, I said we started out with 12 groups. Now we've got over 190 schools, and we also include now cities and counties. So combined, we have over 460 groups in the pool, covering more than 60,000 members. With that large size, we are a self-funded trust. Being self-funded gives us chances to really keep administrative rates as low as possible. So if you cut down your administrative costs, there's more dollars available to pay claims, and you're going to have better renewals. Again, by piggybacking off the state of Minnesota contracts, that's one of the real advantages we have there. So as a self-funded trust, what it means is the 460-some groups basically pay premium in. We put that premium in a bucket. From that bucket, we pay Blue Cross, Health Partners, and Preferred One a fee to be claims administrators and to use their networks. Those three, Blue Cross, Health Partners, and Preferred One, are not setting rates. They don't take any risk in the program. That's why they'll actually compete against PEEP sometimes on their own as a carrier. But within PEEP, they are basically hired to be a part of the program, and they're paid fees. PEEP also uses a tiered clinic model, and I'm going to spend a lot of time talking about that. That's probably the most unique aspect of the program. But it's also a basic part of the managed competition principle. When the state of Minnesota created this plan design back about 15 years ago, it won 2 national awards, and it's worked very, very well for both the state employees and PEEP members once we started using it on the PEEP side also. There is a great deal of choice built into the program. I'm going to talk about that in just a second. But just a reminder that the PEEP rates for the new combined school districts have not gone out yet. They'll be coming out shortly. But I did want to walk through a couple real-life examples before I go through the actual plan designs. When we first started the pool, the Duluth School District was one of the largest groups to come in. I did a presentation to their insurance committee, and it was a cold, cold presentation. There wasn't a lot of nods or positive response from them because the PEEP plan of benefits wasn't as rich as theirs. They had a very rich benefit plan design, similar to your richest plan design. So at first, the thought was we don't want to do anything that would ever give up this very, very rich plan design. Well, we put the proposal on the table, and Gary Westdorf was the Education Minnesota person working in that area, and he actually got them to think outside of the box because there was such significant savings under the PEEP program. They were able to create an HRA for each employee, whether they had single or family coverage, that was equal to the out-of-pocket maximum under the plan. So they guaranteed that no member would have any out-of-pocket expense, and the district still saved about $1.5 million beyond that. And that is the definition of a win-win situation. By thinking outside of the box and using the plan designs in a little bit of a different fashion, they were able to really save a lot of money. In the 11 years of renewals that we've had with Duluth, I was just up there not too long ago, or actually via Zoom. Their average increase over that 11-year period was just under 2%. So they've been very, very happy with the program, and it saved them in the millions of dollars. Second example I want to give you is a very local one, and it's a very recent one. Very similar situation. We put a proposal out for the city of Virginia. Again, the PEEP plan design wasn't going to match their benefit schedule, but there was enormous savings to be had there. It took a great deal of work. We did a lot of presentations to all of the bargaining groups. It took almost a year in time to finally get everything settled, but as of June 1st, the whole city has come into the program. And what they did is they were able to set up an HRA of $2,000 for single members, $4,000 for family members, and beyond that, the city still saved approximately $660,000 on an annual basis. So again, I want to emphasize that PEEP has been instrumental in helping groups see the best way to offer benefits. Sometimes you have to change things, and you have to be a little bit flexible to allow those to happen, but we've had very, very good success, and those are just a couple of the examples why. The next piece I'm going to talk about is the step-by-step sheet. This is what we use for every one of the informational sessions and actual enrollment meetings that we have. The front page is a very nice primer that says, here are the choices that you make at every open enrollment. Behind that are the 3 actual plan designs. The first page is the high plan, which, by the way, if you know anybody that's a state of Minnesota employee, that is a duplication of the state employee plan. The next page is the value plan. That's kind of the middle ground of the 3 plan designs. And lastly is the HSA compatible plan in the back. That plan would have the lowest premium, but it does have higher deductibles and copays. Just a reminder also, all 3 PEEP plans can work with an HRA. The last plan there, obviously, that's HSA compatible, that is the plan that if you wanted to combine it into a health savings account, you would need to pick that one. When people first see those plan designs and they see the grid, they get a little nervous and think, boy, this plan is going to be very difficult to understand. But it's really not. If you go back to the front page of the step-by-step sheet, you'll see that there's basically 3 choices employees are going to make. Step number 1 is real simple. At each open enrollment, each employee decides, do I want the high plan, richest benefits, the value option, that middle ground, or the HSA compatible plan, which will have the lowest premium? High, medium, and low. If I take family coverage, my whole family goes with me in whichever of the 3 plans I would pick. I'm going to be in that plan to the next open enrollment, roughly a year from then. Second choice is going to be new to you guys. Second choice now says, again, at each open enrollment, each employee gets to pick which network of providers they want to use. It's an individual choice. So I can pick from either Blue Cross, Health Partners, or Preferred One. The choice of the network does not change the premium cost. The premium costs were just set on the high plan, value plan, or HSA plan. So the choice of the network doesn't change the premium cost, and it also doesn't change the benefit levels, with one exception. Health Partners as a network pays a better benefit for treatment of infertility, but other than that, plan designs are the same across the board. So each employee is just going to decide which large network, Blue Cross, Health Partners, or preferred one, do I want to use, or if I take family coverage, does my family want to use? All three networks are very, very large and very good. Blue Cross covers 96% of the providers in the state. Health Partners and Preferred One are both around the 90% level. So for most people, everybody you're using for medical care, or the vast majority of those providers, are in all three networks. So it's good to have choices, that are that robust. So that's the second choice. Again, if I take family coverage, my family goes with me in whichever of the three networks I pick. I will be in that network until the next open enrollment, roughly a year from then. The third choice is where the program becomes more unique. And this is the piece that if people are going to be selling against this program, they're going to be hammering on this and trying to scare you with it. The third choice says basically that each member of your family that's covered is going to pick a primary care clinic. It's an individual choice, so I could pick Clinic A, my wife could choose Clinic B, our kids could go to Clinic C or D. Each member picks their own primary care clinic. This is a primary care clinic focused plan, which means you're picking a primary care clinic that's going to become the director of your health care. Because under this program, all of your routine or planned care needs to funnel through that primary care clinic or wherever they would refer you. Obviously, urgent care and emergency situations, you have no control over where you're going. So when it is an urgent care or an emergency situation, you can go to any urgent care clinic or any ER, and it's treated right as if you had gone through the primary care clinic. But again, the majority of your care is going to go through the primary care clinic and wherever they refer you. That's very important because this is a primary care focused program, and the primary care clinic systems are tiered. We call them cost levels. So one of the other handouts there, and I'll talk about that later, actually shows a lot of primary care clinics in St. Louis County, and it shows on the far right-hand side the cost level. The cost level determines your final benefit schedule. So again, each member picks a primary care clinic. You can have different cost levels even within the clinics, but in St. Louis County, virtually everybody is going to be accessible at cost level 2. So when I go through the benefits, I'm really only going to focus on that second column because that's where I think 99% of you would end up. So each person is picking a primary care clinic. I'm emphasizing that a lot to make sure that everyone understands that. Other programs may offer a plan where you can go anywhere, anytime. This plan is saying you're agreeing to have that primary care clinic, be the director of your health care. When the state created this plan back 15 years ago, they looked at how do people access care, and I think it was 93 or 95% of people had a primary care clinic or doctor that they went to. If that doctor or clinic found something serious, they referred them on to specialists. That's basically the way that this program works. So the third choice is picking the primary care clinic for each member. Those are broken down into tiers. The tiering system is what's really helped to hold down claim costs under the program. That's the managed competition principle that actually lowers claim charges. No other program can lower claim charges the way we do under this plan. How that works is once a year, the state looks at every primary care clinic system throughout the state. They get their charge levels, their quality data, and based on that, they rank them into cost levels 1, 2, 3, or 4, with 1 being the most efficient, 4 being the highest cost. Then we turn around to you, the members, and say, here's the deal. Everybody's going to pick a primary care clinic. If you pick the more efficient clinics, the cost level 1s and 2s, we'll give you better benefits. That's the incentive to have you use those more efficient clinics. And it's the driving force to get the clinics to negotiate down their charge levels. Duluth is a great example. When I did all the informational meetings there, I was getting a little bit scared. The first question after every presentation was about the Mayo Clinic. We actually brought in one of the CEOs from St. Mary's Duluth Clinic then, before it became Essentia, and he explained to them how they work with referrals with the Mayo Clinic. The Mayo Clinic doesn't want people driving, 4 hours down and just coming in off the street. They want to work under a referral system too. But the people there needed to be informed as to how that would work. But with Duluth, the St. Mary's Duluth Clinic system initially was a cost level 3. So that had higher deductibles, co-pays, and out-of-pockets. The Duluth employees were not bashful of going to St. Mary's Duluth Clinic and saying, you need to get your charge schedule under control here so we can get down to a cost level 2 and we can see better benefits. At the very first renewal, that worked. They lowered their charge schedule, which was a win-win situation. The plan now saw lower charges coming through, and because they moved from a cost level 3 to a cost level 2, the employees saw better benefits. So this managed competition principle that the program is based on has worked very, very well. Under step 3 in the bold print and about the middle, after I emphasize using the primary care clinic, there's actually more flexibility to that. There are 5 types of treatments where you can self-refer. You don't have to go through the primary care clinic. Those would be OBGYN, chiropractic, mental health, chemical dependency, and vision care for that annual vision exam that's covered under preventive care. Those 5 types of treatments, you don't need to go through your primary care clinic. Each of the networks has a very robust listing of self-referral providers for those 5 types of treatments. All you have to do is call the number on your ID card and say, give me a list of all of the chiropractors in Duluth that are covered under the self-referral, and I could just go there. I would, of course, always stay at the cost level of my primary care clinic. And that's an important thing to remember. Say you pick Essentia and you're in cost level 2, you go in and they find some real serious things. They say, we need to send you down to the university, or we need to send you down to Rochester. Wherever they refer you, you would always stay at the cost level of your primary care clinic. Sometimes people get confused. They go to the statewide listing and they see that the Mayo in Rochester is a cost level 4. Well, that's if you lived in Olmsted County and had picked them as your primary care clinic. When you're being referred there by your primary care clinic, you always stay at the cost level of your primary care clinic. The third choice, the primary care clinic, you can change during the year. Steps number 1 and 2 you were locked into until the next open enrollment, but the choice of the primary care clinic you could change on a monthly basis. You sign up for Essentia and 4 months later your doctor leaves there and goes over to St. Luke's. All you have to do is take out your ID card, call the number and say, I want to switch from Essentia to St. Luke's, and that change is going to be effective on the next first of the month. And one other advantage for your group is, Essentia treats themselves as a hub and spoke. So if I pick one Essentia clinic, I can use all of the Essentia clinics without needing referrals. Similarly, St. Luke's, they treat themselves as a hub and spoke also. So it's actually very, very workable as far as, it seems like a new change to have to use a primary care clinic, but it works pretty smoothly after a while, and we really get very few questions or problems with primary care clinics and referrals after the first couple months once a group has come into the program. Because you can change primary care clinics, it works out well if you have a son or daughter, say they go down to Winona State. All you have to do is call in and say, I want to switch from Essentia to the Winona Clinic in September. Call in and switch them back when they're going to come back home for the summer. So there is a lot of flexibility. If you have a family member that goes out of state or far out of state to school, we have an added benefit level that shows up under each one of the benefit grids as a way that they can receive care out of state. It's a deductible in 70% coverage, and it still goes back towards your out-of-pocket maximum. So there is coverage no matter where any of your family members go. And whenever it's an urgent care or an emergency, if you break your leg out in the parking lot here or on vacation in Cancun, it's going to be covered right as if you had gone through your primary care clinic. So that's a quick run through of how things work under the plan. I'm going to go through the benefits just quickly to give you some idea of how things work. Start with the high plan. I'm going to use cost level 2 as an example, since I said that's basically where all of you will probably end up. Up on top, preventive care is covered at 100%, so you pay nothing. Then if you go down to letter M as in Mary, prescription drugs under the plan are all drugs are broken down into 3 tiers. Tier 1 is going to be generics and very common name brand drugs, and that would be an $18 copay for a 30-day supply. Tier 2 is going to be most of the other name brand drugs. It's going to be a $30 copay, again, for a 30-day supply. Lastly, some of the very expensive drugs at the pharmacy, they're going to be in Tier 3 with a $55 copay. If you're on a maintenance dosage, long-term drugs, you can get a 3-month supply for 2 copays, so you can save basically a copay per quarter by either using the mail order or going in and requesting, the 3 per 2 deal. Those prescription copays, if they would ever accumulate in a calendar year to letter N, that is the prescription drug out-of-pocket maximum. So prescription drugs are separate from the medical under the value, the next plan I'll talk about, and this, the high plan. It takes a lot of 1830s and 55s to hit 1,050, which is the out-of-pocket maximum for an individual, or 2,100 per family, but it is there as a protection for you. When you look back up the grid, most of the other boxes, it says an annual deductible applies. So on the medical side, you'll see letter B has the deductible, and in cost level 2, that's going to be $400 for an individual or $800 for a family max. Say you come into the plan, we use January 1 as an example. January 1, you come in, and on January 10th, you go in for an office visit, and it just happens to cost $400. You're going to pay that $400 out of your pocket or out of your HRA. Now your deductible is done for the year. If in February you need to go in for another office visit, you'd look at letter C, and you'd see that for this office visit, you're just going to pay a $35 copay because your deductible has already been paid. If in July you tear up your knee, you have to go in for arthroscopic surgery, and the bill comes out to $9,000, I look at letter G for an outpatient surgery. Of that $9,000, I'm only responsible for a $120 copay. The rest is covered by insurance. And if I have a real bad year of insurance and I spend the month of November in the hospital and the bill's $500,000, I look at letter F. Of that $500,000, I'm only going to pay a $200 copay. So this is a richer benefit level than it looks like because those interior surgeries, hospitalizations, things like that, they're capped as to what you're going to pay. So it's usually not a percentage. It's usually just a flat dollar for some of the more expensive things. Now, if during a calendar year that deductible of $400 and those various medical copays or medical coinsurance, if they ever accumulated to letter O, $1,700 is my out-of-pocket maximum for an individual, $3,400 for family. So one of the usual questions is, well, does that mean the medical is separate from prescriptions? Yes, on an absolute worst case scenario, you would add the 2 out-of-pocket maximums, but that's not a good way to compare plans because about 3% of people would actually hit those combined out-of-pocket maximums. It is possible, but it's pretty rare that that happens. So that's the high plan. The next option is the value plan. Under the value plan, everything works the same way, except now the premium is lower. Less comes out of your check each month, so you have guaranteed savings. But if you use the plan, the deductibles, co-pays, and out-of-pockets are higher. So what was a $400 deductible on the high plan, on the value option now goes up to $850. The prescription drug maximum that was $1,050 is now $1,250. The medical out-of-pocket maximum that was $1,700 is now $2,600. So you're taking a little bit more risk, but you know that you're going to pay less out of your pocket, especially if it's family coverage. So the value plan and the high plan are very similar as far as design, but the high plan has a higher premium because it has lower deductibles, co-pays, and out-of-pockets. The third plan is different. The third plan, because it does have to meet specific rules to qualify under the IRS guidelines for an HSA, whether you're using it under an HRA or an HSA, a few things are different. The biggest difference is under this third plan, we're going to lump medical and prescriptions back together. So it's a little easier to understand. Also, when you look at boxes B and N, the boxes are cut in half. Top half is if you take single coverage, lower half is if you took family coverage. So I'll just give you a couple quick scenarios here. Say again, I'm in a clinic that's in cost level 2, and I choose this plan. If I am single, I'm going to have a $2,000 deductible. So everything except preventive care, I'm going to pay the first $2,000 of medical and prescription expenses out of my pocket or out of my HRA or HSA. When I hit $2,000, now it drops down into where I'm paying co-pays or co-insurance, where I'm just paying a portion of the bill. When those portions would add up to $1,000, that $1,000 plus the $2,000 deductible would accumulate to $3,000, which when you look at letter N, $3,000 is the out-of-pocket maximum for somebody with single coverage. So deductible first, once that's satisfied, co-pays and co-insurance for another $1,000. When I hit $3,000, both my medical and prescriptions would be covered at 100% for the remainder of the calendar year. That was if I took single coverage. If I took family coverage, everything kind of just doubles. The family deductible, again under cost level 2, is going to be $4,000. So the first $4,000 of medical and prescription expenses we pay out of our pocket or out of our HRAs or HSAs. After we hit $4,000, it drops down into co-pays and co-insurance, where I'm just paying a portion of the bill. When those portions would add up to $2,000, that $2,000 plus the $4,000 deductible would accumulate to letter N, which is a $6,000 family out-of-pocket maximum. If we hit that in a calendar year, we're covered at 100% for the remainder of the calendar year. One last thing before I just open it up to questions. I'm not sure what the effective date of coverage will be for you guys if you decide to come in. If you come in the middle of a year, 9/1 or 10/1, we'll still give you credit for all of your expenses incurred in the 2021 calendar year towards the PEEP deductibles and co-pays, so you don't lose anything if you do come in the middle of a year. So I just wanted to make sure there were no concerns on that side. And again, all 3 of the PEEP plans can work with an HRA, and if you want to do an HSA, obviously the third plan that's an HSA compatible would be the spot to work with. PEEP does not tell you who to use as far as administering your HRAs or HSAs. That's a local decision here, so whomever you're using right now, we would still be able to work with. That is a quick run-through of everything. If you guys have questions, now's a chance where you can, jump up to the microphone and ask whatever questions you have. Thank goodness, here comes one.
I'm not sure if this is the question to ask you, but I will ask the question for somebody whose this pertains to. So I don't know if you're the right person. Do you offer a single +1 in your plan, or is that Blue Cross Blue Shield or one of the other plans that have to offer that?
PEEP will let you pick whatever rating method you want to use. The standard rating method is a single and family, but we have multiple groups that have a 3-tier rating, which is single, 1+1, and families of 3 or more. There's actually a 4-tier rating that's available too. From our side, we don't care because there'll be a set premium that will be due from the district. it becomes a local decision. I always say it's the balloon theory. You know, if you have a balloon of premium that the district needs to pay, if you want to squeeze that balloon in the middle and say people with 2 family members, husband and wife, or a parent and a single child, you can squeeze that down, but then families of 3 or more are going to expand. So every dollar saved by a 1+1 category is actually being paid by a family of 3 or more. So it's an internal cost shift. That's why we say that's your decision. Pete doesn't care which way you go.
That's what my next question would have been then, is it gonna cost our group more for adding that single +1?
No, the rates are the same. You're just doing the internal mix differently, you know, to help families of 2 out, but then you're charging more for families of 3 or more.
Okay. Once again, I don't know if this is a question to ask you, but I know Evelyn Gilbert went through the system of having grandfathered in other years' plans before we could really cut down our costs. Are we still at that point where we have those grandfathers in? Yeah, we were with the co-op, and they had different plans, and at the time of consolidation of 2 districts, there were grandfathered in to certain groups. So we were paying more because the Gilbert group kept this plan, and the Evelyn group kept this plan, and then the new Evelyn Gilbert site kept this plan. Is there anything like that going on that you can answer?
Sure. I can answer just from PEEP. From PEEP, we will move everybody to these 3 plan designs on the effective date. So we won't carry over any old plans for a certain time frame.
Okay, thank you.
A quick summary note then, and I will finish things off. But PEEP being a true state plan, and we're very transparent. Everything is laid out there as far as all of our renewals. The state uses Deloitte as the actuaries and underwriters to prepare rates. We don't play any rating games. We've taken in all kinds of groups that suddenly at one time saw their rate increases at 40 and 50%. Because that individual group happened to have some very high claims. We haven't done things that way. We pool everybody's claims together. You know, when you look at that first sheet that talked about our claims experience, over 12 years, our worst year of claims, our worst year of increases, you know, was around 8%. So the whole idea of spreading risk over a very large base has worked very, very well under this program. And, you know, because we're the state, we do things pretty simply. We can't cut any deals for anyone. You know, if you came back and said, boy, your rates are on the table, their incumbent carrier had told them they're probably looking at about 15% again. So they came in to deliver their renewal, and it was 15.6, I think, something like that. The Duluth Insurance Committee handed them the PEEP rates. And the rep said, well, why don't you let me go back to the office? There might be some new claims information to look at. Sure enough, 3 days later, they came back with a rate that was almost exactly what the PEEP rates were. You know, how is that for a coincidence? The Duluth Insurance Committee said, we don't want to do business that way. We want you to give us a best fair rate right up on top. Because if you're going to cut our rates 9%, just like that, one of 2 things had happened. Either you were being charged too much up front, or you're buying down business. You'll see that from various groups out there, that they'll say, you know, you deserved a 15%, but we're going to buy it down with reserves to 7%. Well, those reserves are necessary to pay future claims. We don't do any of that kind of thing within PEEP. And Duluth said, you know, that's not the way that we want to purchase something as important as health insurance. So, you know, they moved into the PEEP program, and they've been very happy ever since they did. So I encourage you, if you want to talk to another school, talk to the Duluth people, see how it's worked out for them, or even easier, talk to the city of Virginia. They can tell you how this whole process worked and how the transition to PEEP, it was a little bit ugly in that they had to do a lot of bargaining to figure out how we're going to spend all the savings dollars. But that's a pretty positive message to have these days as to how we're going to work through savings. Any last questions? Otherwise, I thank you for your attention.
So we'll have one more starting up here in a little bit from the Northeast Service Cooperative.
for the administration and a plan for staff, both on the teaching side and on the service support side. Before I begin, I want to mention one thing. I had my semi-annual dental visit to Dr. Miskovich today, and I wanted to talk, he loves to talk hockey, so I wanted to talk hockey, but he wanted to talk about the school district. He is just thrilled as a parent and as a business leader with what's happening here at Rockridge. I know there's a lot of work in front of you, but the community really supports what you're doing, the bold steps you're taking, and what it means for the district combined. So I just want to thank you. We're excited about that, and the community is very, very excited. Let's talk a little bit about NESC. Again, NESC currently writes the health plans for what used to be Virginia, and at one time we wrote the health plan for Eveleth Gilbert as well. Eveleth Gilbert is now working with PEEP. Big picture, we're 7 Minnesota service cooperatives. We came together under a joint powers authority called the Minnesota Healthcare Consortium to work together as 7 into 1. NESC, as part of that statewide coalition, is dedicated to the best public sector insurance solutions for school districts throughout the state of Minnesota, particularly in rural areas like our home area right here in the Rockridge area. The materials that you'll see coming out from us are branded with both NESC and MHC. It matters, but it's really essentially the same thing. NESC is the regional focus. Been there all along, it continues. MHC is our statewide coalition. Both references refer to the program we deliver to you. Statewide NESC is not a one-size-fits-all approach. You're going to hear that theme today in the next 20 or 30 minutes. Instead, we mean to take regional delivery right down to the local level. We can customize the solutions you have, and we've done that in Virginia. 2 plans. One for one group that wanted this, one for another group that wanted something over here. So we can customize right down to the local level, and that's one of the many benefits of our NESC pools. Why do school districts participate? Well, we listen to our members, and here's some of the responses that we get. First of all, greater stability and predictability. All providers in the network are at the same cost. There's no tiering for MHC NESC plans. And the benefit sets, unless you want to negotiate a change, remain the same. They remain the same. That's been popular, we know, in Virginia. In Eveleth Gilbert, that local control led to a change. That's fine too. And now there's going to be a change one way or another, isn't there? At MHC, we're able to leverage the scale of our statewide coalition, negotiating the best-in-class rates, fees, services, and plans. Again, working together statewide, we got the power of a statewide coalition under the Joint Powers Agreement that can be customized to be flexible to fit Rockridge. Flexibility in plan design is really our hallmark. And you're going to be going through that change process here in the coming months. You have a voice in the direction of the pool. Greg Miller, who's with us today. Greg, by the way, thanks for the invitation. And Superintendent Noel Schmidt has been active in our advisory process over the years from time to time, less so during the pandemic. They've been helpful. We get feedback. And what I like about people like Greg, Noel, and others is they take a look at what's right for Rockridge. Not what's right for the service co-op or PEEP or Health Partners or Medica or somebody else. What's right for Rockridge? And so we want to be held accountable to fit the needs that you have here at the local level. But your voice is at the table, locally, regionally, and statewide. Increasingly, folks that maybe wonder why they're in a group plan and they don't have any chance to opt out of it are saying, what's the value for me? I wasn't sick last year. I went for an annual physical, everything's fine. I'm not sick this year, the family's doing fine. Why am I paying these premiums? Group health plans require really, essentially, that you all come together. It's really a union kind of proposal, that you spread that risk to help your neighbor or the employer coworker down the hall. So people are saying, if I don't use healthcare in 2021, what's my value? So what we've done is we've taken that back and we've expanded our wellness and clinical programs designed to meet the needs of not just when you need acute care, but when you're pursuing your health and wellness goals. And finally, as a local service cooperative, you get support from local staff. Some of that sometimes rings hollow because you say, well, so what, Paul? What's the deal? You might live 3 blocks down, which we do, I do, but who cares? Here's where the rubber hits the road. For our full-time staff, Jeanette and I, for example, you'll meet Jeanette in a moment, we're under the same plan Virginia has. She is the funding manager for the statewide MHC arrangement, $450 million a year. And I'm currently working on loan as part of my agreement for Northeast Service Cooperative as the executive director for that coalition. So we have a seat at the table, locally and regionally, and these plans are our plans. We're not selling something to you that we don't buy ourselves. And I think that's always resonated with me because we can look people in the eye and say, yep, we know how this works because we use it every day as well. We've used it on the years we're healthy, and we've used it on the years when we're sick. That's kind of a broad overview of the Northeast Service Cooperative and the Minnesota Healthcare Coalition. Jeanette Malazmone, who's really on point for a lot of what we do, is up next, and she's going to dig a little deeper into the advantages of this particular health plan proposal. Jeanette?
So as Paul mentioned, I'm Jeanette Malazmone. I work in the Member Services Division of the Northeast Service Co-op in Mountain Iron, and of course that includes our health insurance pools, which is why we're here talking to you today. I have to say that it is good to be back in my old high school. I won't date myself as to the year that I graduated. I'll just say that as an adult, you come into these hallways and you say, gosh, they look a lot smaller than they did when I was a little kid. So that says something, I guess, in that child's mind's eye. Many of you are on a health plan for a number of years. You may tend to overlook some of the benefits that you have that are maybe unique to your arrangement and think that they carry forward to other health plans, and that isn't necessarily the case. So I want to make sure I point out some of the things about the programs that you have today through the Virginia teachers that are insured and other staff here from Virginia. The NESC plans are designed with ease of use in mind. Our plan designs are straightforward, they're not complicated. They have what's called open access to all the healthcare providers in the state of Minnesota and in, throughout the United States through the agreement that we have with Blue Cross Blue Shield. That includes mail. Open access is an insurance term that means that you can go wherever you wish to go to seek care. You're not limited to certain providers. You could choose to go to Essentia today and St. Luke's tomorrow, and there would be no questions asked. That's your choice to go ahead and do that on the plans that we have. And doing so, you still have benefits covered. So it's not that you made a mistake because you chose to go somewhere else. You still have everything covered underneath our plans. If you need to seek a specialist or go to a specialty care clinic under our arrangement, you may do so. Nobody's going to ask questions. You don't have to ask permission. You don't have to fill out any paperwork. And I think this is really important because when you're having that acute event or that scary event that's happening to you, the last thing you want to do is try and navigate your healthcare plan. You just need to go and seek care. And that's what we want for you. Our plans have one ID card for prescriptions and medical care. And they have a comprehensive list of covered drugs and pharmacies with which to fill those prescriptions. Our plan designs, I already mentioned how they are straightforward and easy to use. Those of you who receive their insurance from the Service Cooperative today are in 2 different plan designs. The first plan design is a copay design, just like it sounds. It's a copay plan. You pay a copay for the services. The second plan is a deductible plan, and that's what that means as well. Pharmacy and medical accumulate to the deductible. Everything is covered after the deductible is met. Today, there is an $1,850 single deductible plan, and for family, that would be $3,700. These plans are negotiated with your employer. We pledge to keep them constant, which means from year to year, the co-pays or the deductible will remain the same without changes. This is one of the major benefits of our program. Holding benefits at the negotiated level while we hold them constant at your request to make changes is certainly at your benefit. If you choose to make a change, if you and your employer come together and decide that, yes, in fact, we would like to make a change to the plan, we can accommodate that, but we don't do it automatically. It's at your request. So an example of that would be, currently, again, you have an $1,850 single and a $3,700 deductible plan. In the event that you wanted to say, we'd like that to be 2,000 and 4,000, we would take that information from you, recalculate your premium, and provide that to you, but only at your request. We would not automatically increase them. We also have the benefit of being able to customize your plan. So if you want to add a particular benefit set like infertility or bariatric coverage, we can do that for you. They're not shelf plans. We can do anything that you would like. Sometimes that's overwhelming, and so we're happy to come to you with a couple of suggestions, and that might be what we need to do as you join together. So again, today you have 2 current plan designs from us. Tomorrow, in order to meet satisfaction of those who might come onto the plan, we maybe need to put together a couple additional plan designs to give some choice. Offering choice often adds to satisfaction in the plan that you have. We also have flexible timing for you. As your 2 groups are coming together, it's going to take some time to do negotiations and make a decision, and we're willing to accommodate that for you. We're happy to meet you when you're ready. And finally, when you work with a service cooperative, you renew for 1 year at a time. We don't lock you into a longer time frame. That means that we have to work hard on your behalf. You'll vote with your feet. And so we want to make sure we're delivering you the best product so that you stay insured with us. Health insurance to us is not just acute care, hospital and clinic use when you're sick. We've put together a comprehensive package of wellness programs that accompany our arrangement. Learn to Live is one of them. It is at no cost to you. This is an online program that is anonymous. It's for adults and children aged 13 and above. It handles things like substance use, depression, anxiety, and worry. It's free, again, no cost to you. We've seen a lot of increased use in this program as a result of the pandemic. No kidding, right? Who doesn't have some stress and worry as a result of what we've been through this last year? Another program that we have is OMADA. This is a diabetes and diabetes support program and a diabetes prevention program. It's aimed at a lifestyle change. It has weekly modules that you'll read. It engages you with a health coach. It encourages you to monitor the food that you're eating and record that food. You can engage with it as much as you'd like or as little as you want, especially with that health coach. I can tell you that I went through this program just so I could speak to folks like you about how it works. And I recorded all of my food for the day, and I did so for about a week, and my health coach engaged with me, and she said, you know, I noticed that after dinner, you often have a, 8 p.m. Schwann's bar. Because I was honest, I recorded that I ate the ice cream bar. And she said, perhaps you might consider taking a banana and mixing it with some cocoa and freezing it in the freezer, and then pulling that out as your ice cream treat. And I thanked her, and I said, thanks, that sounds yummy, I'll give that a try. I did not try that, okay? I decided that maybe I would just not eat the Schwann's bar instead. And so I did curb that behavior because I had somebody looking at me or watching me. And certainly I could try that banana smoothie in the freezer if I wanted to, but it did make that change for me. We do hear from a lot of superintendents and teachers who have gone through that program and have shared with us what a life-changing event that was for them. So we do think it's an impactful program that we offer. One of the other programs that we have is ShareCare. This is the opportunity to earn a $20 incentive. This is step-based, so you are encouraged to get so many steps and do steps every day for at least 20 days in a month or so that you can earn that $20 incentive. Not everyone does step-based things, so if you're a swimmer, there's a conversion chart so that you can go ahead and convert those times that you've spent swimming into steps. You don't need to belong to a gym, but you may belong to a gym. And we found that this program is often quite popular amongst our population as well. Smart Shopper is an incentive-based provider choice program. I think the best way to describe this is consumerism in healthcare. You can shop for low-cost providers that give you the same 3D mammogram as the provider down the street, but at a lower cost. And that's because providers have different reimbursement rates. If you take the time to shop, you could earn an incentive, and that incentive is earned because it costs the plan less, and we share some of those savings with you. Of course, this is completely voluntary. You do not have to participate in any of these programs. We often find that people are quite content with the clinic that they're going to, and they don't access Smart Shopper. but in the event that you wanted to, you could earn an incentive. The next thing I'll talk about is the HSA, VEBA, and Flex spending accounts that are currently administered through Further. Both Evelyn Gilbert and Virginia have individuals utilizing these spending accounts today. We completed an RFP for this spending account arrangement this past fall, and the results of that RFP were to have lower fees that the district pays on a monthly basis, as well as increased interest rates to account holders. Account holders are people in this audience. So those of you who have HSAs and VEBAs from Further, you're earning a higher interest rate based on that RFP that we went through. Higher interest rates than what you can get at the local savings account. We also have in-house expertise in this area. Marlo Peterson is on staff with the Northeast Service Co-op, and he is happy to come out and join a group like this and explain the benefits of utilizing an HSA or a VEBA or even Flex. Sometimes there's some rules around that, and it's maybe a little bit hard to navigate. Marlo does a beautiful job of explaining it at an easy level, and even if he just explained the question that you asked, he explains it again just like he never said anything, which is great. You feel like you get that personal touch and certainly get all of your questions answered. And with that, I'm going to turn it over to Brooks to talk about the next section.
Thank you, Jeanette. Good afternoon, everyone. It's great to be having an in-person meeting. These have been few and far between over the past year. So, wanted to spend a little bit of time. So I'm the statewide consultant for the Minnesota Healthcare Consortium. Been working with MHC in some capacity for going on 8 years now, and so I've had the pleasure to work with the 7 regions to help set the strategy on a statewide basis and coordinate a lot of the activities as we move forward. So I'm going to spend a little bit of time talking to you about MHC specifically, and then go into some depth about a request for proposal process that we went through and how that'll result in an administrator change over the course of the next 18 months or so. So, Paul touched on some of this, but MHC, MHC provides the cost savings and flexibility of being in a self-insured arrangement with the financial security of being in a pool. So, as a self-insured employer, you have more flexibility from a plan design standpoint. Jeanette talked about some of the programs that are embedded into the MHC and the Northeast Service Cooperative offering. You get that flexibility. You remove some of the taxes and fees that come with being a fully insured employer. So you get the benefits of, as an employer group, as a district, you get the benefits of that self-insured arrangement with the financial security of being in a pool. The coalition leverages the statewide scale that we have. So over 300 groups across the state participate in the Minnesota Healthcare Consortium, and we take that scale to leverage best-in-class rates, fees, terms, and conditions. I talked about the flexibility. So you're in that pooled arrangement. You have the ultimate flexibility as it relates to plan design. So you are not boxed into a handful of plan designs that you can choose from. We have the flexibility to be able to accommodate your unique needs as a district, and we work closely with the key decision makers and partner to determine what benefits make the most sense. But you have the flexibility from a network standpoint, and you have the flexibility from a plan design standpoint. And then there are comprehensive, programs and value-added services that are baked into the MHC offerings. And Jeanette touched on some of those, what we're doing in the health and well-being space, in the behavioral health space, the fitness space, the clinical space. So these are very important, and they contribute to what we want, how we want to contribute to the communities that we serve throughout the state of Minnesota. And I think, very important as well, and you shouldn't lose sight of the fact that, the regional service co-ops and the groups that are a part of the regional service co-ops, they have a say in the future direction of the program. So, Paul mentioned advisory groups and the opportunity to be able to provide feedback. That is taken, very seriously and consolidated at a regional and statewide level, and helps contribute how we think about the future strategy of the Minnesota Healthcare Consortium. So I want to touch with you, Jeanette mentioned the medical spending account RFP, which resulted in reduced fees for all the groups that participate in the spending account arrangement, better enhanced rates of return on the accounts that are in place. We're also required to conduct an RFP for medical claims administration services every 4 years as well. So we conducted that process. We really kicked it off last summer. And you know, as part of this process, the 7 regional service cooperatives come together in partnership with industry experts. So, you know, I actually helped run Point in conjunction with Kinney and Associates, so MHC's legal counsel, to facilitate this RFP process. You know, essentially in this particular scenario, you know, we want to make it clear that the Minnesota Healthcare Consortium and the Northeast Service Cooperative are the predominant risk-bearing entities here. So they're the ones that are holding the majority of the risks. The claims administrator is the one that is processing claims, providing network access. So we've talked about the network access to doctors, clinics, hospitals, pharmacies. So they're the ones that are administering the benefits in conjunction with MHC and the Northeast Service Cooperative. But like I said, MHC, Northeast hold the bulk of the financial risk and determines the key offerings. So when we talk about the health and well-being offerings, the clinical offerings, that is at the direction of MHC. So as we went out to bid, you know, we wanted to make sure, you know, that we maintained what was valued as part of the MHC offering. And, you know, some of those things are broad network access, the wellness services, and we also wanted to be able to address affordability concerns. So we actually kicked off the process in July of last year with the development of our strategy and an RFP team, RFP committee to really work through this, led by myself and Mark Kinney. And again, we wanted to expand on what we were currently doing, provide more services, but do so at a lower cost. And we were extremely pleased with the results that came out of the RFP process. So the RFP process resulted in bids from 5 administrators in the state of Minnesota. So the incumbent Blue Cross Blue Shield and 4 other administrators. And you know, that process, like I said, spanned multiple months. It included an in-depth analysis of the capabilities and the services that the administrators offered. It looked at the fees that were associated with this, so the administrative fees in addition to the reinsurance fees. It looked at the partnership model that was being put forward. And as part of this entire process, we looked at what, if any, disruption there might be. So if we look at the doctors, the clinics, the specialties that are in network, what a change might potentially look at. We looked at the financial impacts of all of that. And we worked closely with all of the bidders through a finalist process, through a finalist process, and gave them multiple opportunities to put their best foot forward as part of the arrangement, including facilitating a best and final offer process. So, you know, administrator update. So today the MHC program is currently administered by Blue Cross Blue Shield of Minnesota. So when I talked about the things like processing claims, providing network access, customer service, that's facilitated by Blue Cross Blue Shield of Minnesota. Starting on January 1st of 2022, so that'll be the first start of a transition. A transition is going to be taking place from Blue Cross Blue Shield to Medica, which is, you know, one of the largest nonprofit insurers in the state of Minnesota. So they'll be, the administration of the MHC and the Northeast Service Cooperative Program will be transitioning from Blue Cross Blue Shield to Medica. You know, this was a result, again, of a very long and comprehensive process that we went through. We looked at, we wanted to facilitate this process early enough so we could get in front of any transitions and ensure that the transition that is made starting on January 1st of 2022, and just so I'm clear, that transition date is for groups that just renew on January 1st. If you renew later in the year, you won't begin that transition until a later date. But you know, the reasons for making this change is the new relationship, it's going to preserve and actually enhance the benefits that MHC and the Northeast Service Cooperative offer to participating groups. There were significant fixed fee savings that are guaranteed for 5 years that are going to be realized as part of this new arrangement. Those fixed fee savings in the form of administrative fees and in reinsurance, coupled with the comprehensive services and programs that Medica is bringing forward, are going to result in lower premiums for member groups throughout the state of Minnesota. Medica allows MHC and the Northeast Service Cooperative to maintain a comprehensive medical and pharmacy network and consistent plan designs. And they have a comprehensive open formulary, drug formulary as well. We looked at all of these areas and see very, very little disruption throughout the state of Minnesota. So that was very important for us to be able to maintain that open access and that flexibility that'll come with this new partnership. And Medica has presented a strong partnership model with statewide support in the communities that we serve throughout the state. And they've shown their commitment to the public sector business throughout this entire process. So again, Blue Cross will continue to play a part in this relationship up through 2022. The transition will start of administrative services will start on January 1st of next year. So with that said, and we're happy to take any questions, we want to make sure that you walk away with 4 key takeaways from our presentation here today. First and foremost, with the Minnesota Healthcare Consortium and the Northeast Service Cooperative, you're going to get maximum flexibility within a pooled arrangement that's going to provide rate stability for you from 1 year to the next. The Minnesota Healthcare Consortium and the Northeast Service Cooperative is committed to promoting health and well-being and is committed to continuing to incorporate those comprehensive programs as part of their offerings. So it's a big part of what we stand for. We want to make sure that the programs are in place to support healthy lifestyles and to get the services and provide the access that you and your family members ultimately need. Northeast Service Cooperative employees, you heard Jeanette mention it earlier, and Paul, they live and work in your communities and they advocate on your behalf day in and day out. And then lastly, MHC and the Northeast Service Cooperative work on your behalf, and you have a voice in the program and the future direction of the program. So with that, we want to thank you for your time here this afternoon, and we'll open it up to any questions.
I have a couple questions, just for my clarity. When Jeanette was speaking, she spoke to being able to go into any clinic, any hospital, anywhere we want to go, versus PEEP who had different cost levels. So when I go into, say, the level 1 clinic in Eveleth, I pay their amount, and if I go to Rochester, I can with PEEP go to anywhere I want to go, but it's the cost level. If Eveleth Clinic refers me to Rochester, I pay what I would have paid if I'm sitting in Eveleth. So under your plan, if I go to any of those clinics, how's the pay scale going out on that? Am I paying what to Rochester, what Rochester is charging? Am I paying what Essentia is charging? Am I paying?
You're going to pay based on what the plan design says. So if it's a co-pay plan and you're going to Rochester for a doctor's visit, you're going to pay the co-pay visit for any clinic. Doesn't matter if it's Rochester or Essentia down the street. If you're on the deductible plan, then once the deductible is met, so the first expense that you have, no matter where you go, one deductible. Once that deductible is met, then everything above and beyond that is covered.
Okay, so depending on the plan and the deductible, that is what you're paying if I'm hearing
Correct.
that right?
So today you have 2 plan designs here. One is a copay plan, not to be confused with the deductible plan, because they're different. The second one is a deductible plan.
Correct.
The plans work a little bit different, but you pay based on what the plan is, no matter what provider you go to. That's the, more of the takeaway, I think.
Okay, so if I, I'm just looking at what I know right now, and I know PEEP, because that's where I've been at. So if my PEEP deductible was $1,000 versus a plan with the co-op, who the deductible might be $5,000, no matter what plan I'm on, I have to meet that deductible at $5,000 anywhere I go. Is that correct?
If you choose the $5,000 deductible plan, then yes.
Right.
So certainly, we realize that we have two bodies coming together here to make decisions about what kind of insurance you want. And as I mentioned earlier today, there's 2 plan designs, but there's nothing stopping us from having 4. So if a $1,000 deductible plan is important to the staff here, we can put in a plan design with a $1,000 deductible in it.
Okay.
And you could elect that plan.
Okay, I just wanted to make sure that I was clear on that before I went forward. Okay, so, something that Brooks said, can't read my own writing. Oh, it had to do with the plans, either the one plan or multiple plans. So with with the plans that we create within our bargaining unit, there are plans based on that. We can't go in individually, say, and have our own plan. So if I wanted Blue Cross, or whatever it is, the single plus one, and somebody else wanted a family, our bargaining unit would have to agree on those lanes. Our single, our family, our single plus one, an advanced one, we have to agree on those plans, am I correct?
So I think you're speaking to what you're negotiating with your employer as far as what plans to offer and what contribution to go to them. Do I have that right?
Yes, correct.
Okay. So certainly we don't get in the way of whatever negotiations you have with your employer. So certainly whatever you negotiate, we will help find a way to administer that for you.
Correct, but we don't have any plan that I want. It's what our bargaining unit wants.
So every district does this a little bit different, and what I'm hearing from you is that your bargaining unit chooses the plan. Do I have that right?
Correct.
Some schools, they offer 3 plans and they just put forth a cap as to what they'll cover, and then individuals can choose from that. So
Okay.
certainly we're happy to work with you on however that works at your district here, and if your bargaining unit wants to negotiate 2 plans, we don't have a problem with that. But your employer might say, it's too hard to administer that, or it's too hard to determine what, contributions could be. So certainly it's a conversation between you and your employer to determine what's the best plan for your bargaining unit.
Okay. I think that's it, thank you.
I just wanted to ask about percentage of increase for the premiums over the past years. Is there an average, and is that average just with the Northeast Service Co-op people, or does that include everybody that's in the MHC also?
Could you repeat that last part?
The increases, the percentage of increases, is that just for the people that are in the Northeast Service Cooperative, or is that a combination of the people that are in the Northeast Service Cooperative combined with the MHC people? Where does that rate come from?
Regional.
It's regional. So it'd be just the Northeast Service Co-op then. Okay, and what is the average increase for premiums, Ben?
It varies from year to year based on the utilization of the pool. If I did an average of our school group over the last couple of years, I would say we're probably in the single digits, 5 to 6 range. But keep in mind, we're holding benefits constant. So when people publish about how they have lower increases, sometimes the way that they're able to accomplish a lower increase is because they've made benefit changes. So by changing a copay or deductible, that's how you can drive down that lower percentage increase year over year. Our program, because we make a pledge to you to say that we'll hold things constant and we won't make those changes unless you ask for them, we can't make that automatic lowering by changing benefits then. We leave that up to the group to make a decision. And sometimes groups do make a slight change to lower their local premium.
I don't know when this all changed, but I know several years ago, we had like a 20% increase in our premiums. You know, I mean.
Are you Virginia or Evelyn Gilbert?
I was Evelyn Gilbert.
Sure. So we have changed our program since Evelyn Gilbert has been a participant.
So you're talking averages in the single digits then?
Trend is typically around 8%, and we strive to get to that 8% or lower to meet medical trend.
What about Virginia? What has their average increase been?
Oh gosh, I'm sorry, I did not look that up before I came here. When we take a group of Virginia's size, we tend to look at it over a 5 or 6 year period, and I can tell you the last time that I looked at that, all of our larger groups were at trend or better. Some groups actually get a decrease from year over year, so, or a zero, a no rate change. So it does vary a little bit, but when I look at a 5 or 6 year block, it's typically at trend or even better.
If I may, Jeanette's answer is correct. The other thing that we do it all the time. Our staff would be happy to take a request from Mr. Miller or Superintendent Schmidt, and we could look at a 7-year trend from Virginia, or the last 7 years Evelyn Gilbert were in the pool, and give you the exact number. So Jeanette is right on about the single digit, the trend regionally and with our larger groups. That's good news. But if you want the exact number for the district formerly known as Virginia or the district formerly known as Evelyn Gilbert, we'd be happy to run that for you. Just ask.
Hey, Paul.
How you doing?
How you doing, man? Hey, just for clarification, because I thought it was important, the deductible for single for Virginia, $1,850, $3,600, $3,700 for family. That is a combined prescription and medical costs as well, combined the both versus PPAD, it's separate, correct? I just want to make sure the audience understood that.
Correct. Medical and pharmacy accumulate to the same deductible, just one deductible.
Thank you.
That's coming from a math teacher. The other thing we want to make clear too is that statewide for MHC, we are active, the three of us, in our statewide program. Brooks and I are 2 of 3 members on the legal transition team, putting the new contract together coming out of the RFP, and Jeanette is 1 of 4 on the statewide transition team. So when we talk with authority, we'll run data, but we also are heavily involved in Future Forward. And part of the RFP that Brooks did mention is when we ask for proposals from Blue Cross, Medica, and UHC, we said that any work product that comes as a result of the RFP process will be embedded into our initial contract discussions. So we're making sure we're keeping that trail alive. So when we look you in the eye and say, you can keep the plan you have, that's something that we want to follow through on. I want that. I want that for me and my wife, and I know you want that too. So, but the good news, as Jeanette said, is there's some opportunities here. If there's a multi-plan design coming out of Rockridge, let's do it. That's up to you. Thank you all very much. Good luck. Let us know how we can help.
Enjoy the sunshine.